Hello, everyone. Welcome back to the HR Rehab Podcast. I'm your host, Nick Kane. Today on the podcast, we have our clinical cases edition where we get a clinician and try to work through a particular case that they've experienced and touch on around their decision-making and their processes within rehabilitation, some of their learnings from that to hopefully pass on to you as a listener. So today we have our guest being Michael O'Sullivan, and Michael's a Senior Sports and Musculoskeletal Physiotherapist from Ireland working at the UPMC Sports Medicine Centre. He's extensive experience working in elite sport. He's got a keen interest in lower limb and muscle injuries, and he's undertaking research investigating the outcomes of hamstring tendon injury by undertaking a professional doctorate through the University of Limerick in innovation and with the human performance at City Football Group or City Football Club. So we will include his recent systematic review on time to return to play and re-injury rates of hamstring injuries with and without intramuscular tendon involvement within the show notes. And within this case, speaking of his systematic review there, yes, we'll be talking through a 3C intramuscular hamstring tendon injury. Michael provides some great insights into some of his early loading, what deficits they thought this athlete was experiencing and the timeframes they felt were needed to address those deficits and how to tease out some of that within our rehabilitation, some of the decision-making processes around return to play, and any consideration around surgical management was touched on as well. So some really good insights. I really appreciate Michael sharing with us. And yeah, I think it was a great listen. So good to have another episode of the Clinical Chats back. And before we do jump into that, obviously we have some excellent hamstring content. I encourage you to check out Sports Map, mainly speaking to Fergal Kieran's masterclass coming up. So where he talks to T-junction injuries. And for those interested in other areas, obviously we've had Peter Malliaris, Achilles tendon rupture masterclass recently. And Fiona McBarton from Red Bull talking around chondropathology within the knee is probably our most recent masterclass to drop on the platform. And look, event-wise, we're really excited about our knee acute capacity coming up in February in Melbourne, where virtual access is available for those who are overseas. And then we can't wait to head to the UK for the athletic hip and groin course in Manchester early June 2026 with a stellar lineup. So all that information is at the sportsmap.com.au website. Well, thanks again for tuning in and listening, and let's see what information we can gather from Michael that helps us inform our practice when we're sort of dealing with our 3C hamstring injuries. All right, Michael, welcome to the How I Rehab podcast.
Hey, Nick, how are you? Thanks for having me on.
Mate, I am well, thanks, very well. Good to have you here, and I'm about to say good to have you back on here. Now, we haven't had you as a guest before, but we have recorded this podcast before, but we had a few technical issues with the recording, so we're actually doing it again. So I think, it might be better the second time around.
Absolutely, second time's a charm.
So the first time we had a chat, we obviously worked through this clinical case as well that we're going to talk through today. It was really interesting, got lots out of it, lots of practical components, and I get asked a lot by physios around the traps around, how to manage intramuscular tendon injuries at a higher grade one, especially more that mid to late stage, and how do they get the balance right between trying to address the injury and the hamstring strength and what have you, and getting it back to sprinting in the field work. So we'll go through that. But before we do, why don't you tell us a little bit about your career to date and what you're doing now?
So when I left school, I started studying civil engineering, and I actually left it halfway through after year 2. Just with a change of mind. It wasn't really what I was passionate about, so I moved into physiotherapy, and I qualified with an undergrad in physiotherapy from UCD in 2014. In 2015, I travelled to your part of the world over to Perth to do a postgrad cert in manual therapy with Toby Hall and Kim Robinson at Curtin Uni. Then in 2022, I completed my MSK in advanced physiotherapy at the University of Hertfordshire, along with my MACP accreditation. I kind of broached into strength and conditioning a little bit in 2023, getting my UKSCA done. And in 2024, I started a prof doc with City Football Group and the University of Limerick, working closely with John Kiley from UL and Michael Giacomas from City. And in terms of working post to date, I've kind of had a mix of clinical and elite sports work, which I think gives me a nice balance of maintaining both sets of skills. I worked full-time in football with Waterford FC as lead physio from 2017 to 2020. I've done some contract work with Irish Athletics and the Football Association of Ireland. Since 2021, I've worked part-time as a clinical specialist in UPMC Sports Medicine Clinic in Waterford, which is a satellite clinic of Santry Sports Surgery Clinic. And since 2022, I've been lead physiotherapist for the Waterford senior hurling team. And earlier this year, I was lucky enough to spend some time working in City as a rehabilitation physiotherapist.
Beautiful, mate. It's a nice summary. I guess today we're chatting around hamstrings, and you mentioned your prof doc. Why don't you give us an idea on what that is on, and in doing so, fill us in, I guess, on where your interest in hamstrings came from.
Yeah, so my prof doc at the moment with City, we're looking at subsequent injuries. So with the idea of that when an athlete returns from an index injury, they're more likely to sustain a second injury that is not necessarily a re-injury. So for instance, if they hurt their ankle first couple of weeks of the season, miss 3 or 4 weeks, come back, it's later on that season they're much more likely to get another injury. And it seems to be that the most common subsequent injury is actually hamstrings. So we're still in the preliminary stages of data analysis on that, but I think we're going to get some really, really interesting pieces from it. And my own clinical interest in hamstrings, I suppose, comes from the mixed outcomes I probably had early in my career. I had some guys did very, very well, and some guys that broke down. And I think in the last 5 or 10 years, generally the severity of these hamstring injuries, certainly in the sports I work in, has increased. And along with that, I think our knowledge of structure and specific rehabilitation protocols has increased significantly too through Noel Pollock's work with the British Athletics Group. I think the combination of both the increase in severity and the increased knowledge we have in the area, I think hamstrings provides a great opportunity for us as therapists to challenge ourselves from a clinical reasoning perspective. And I think ultimately it's that challenge that really excites me about dealing with hamstring injuries.
Yeah, beautiful. And we'll chat through that obviously in more detail where you get obviously that interest and some of that structure and function around it. Now, you did do a systematic review, mind you, on intramuscular tendon injuries, which we will include that in the show notes. But did you want to give us a quick little summary of what that was and maybe what sort of the outcomes or findings suggested?
Our systematic review looked at outcomes following intramuscular tendon injuries. So it's generally accepted that these injuries need a longer return to play. And our analysis showed that when grade isn't taken into account, the presence of an intramuscular tendon injury took 15 days longer to return to play than those injuries that didn't. Our analysis found no changes in re-injury rate. Some of the other findings associated with our systematic review were just around the lack of quality of evidence investigating outcomes of these injuries. The majority of the studies weren't blinded, and there was a huge range of return to play timeframes in the published literature. This doesn't really help the clinicians with the prognosis for when they're asked the tough questions by a coach, when is this player going to be back? I think some of the nuances around that are basically that not all C injuries are the same. For instance, if the majority of the injury is in the myotendinous junction with a small extension into the intramuscular tendon, that's going to be graded as a C on an MRI report. However, if there is more damage to the intramuscular tendon, that may be associated with a longer return to play. I think it's important for clinicians just to have a good relationship with radiologists if possible, to be able to ask the questions and just get that bit more information around how much involvement is actually there, because that's ultimately going to affect the prognosis for the athlete going forward.
Yeah, lovely. I was chatting to someone today actually in another podcast, which Peter Blanche, for those who want to either jump on it and listen, and we were chatting a little bit about sort of something you just mentioned there, a coach wanting to know how many weeks they're out. And, you know, let's say if you say they're out for 8 weeks, once the athlete hears that, reality is they'll probably miss 8 weeks, no matter how well you go. And, you know, he was, I guess, more advocating an approach where you can say, well, look, he's not playing this week, but let's see how we go in the first week of rehab. And we'll use a true criterion-based rehabilitation approach. And when he's ready to play, he's ready to play. That sounds easier said than done in the football environment and things where coaches sort of want to know numbers and they're so used to that. What's your view on that, and how do you think you can, I guess, sort of navigate that process?
I think if management are open to that, fantastic. From my experience, you know, from a fixture planning, from a training numbers planning perspective, management want to have some sort of ballpark figure. that we need to, and I think if we can provide a range of time, so if it's a 6 to 8 week mark, and as long as we can, I suppose, come to a shared decision making with the athlete and the coach in terms of how much risk are we happy to take here. And often we can, as a physio, bring the decision to the manager and say, okay, do we want to take a low risk, a moderate risk, or a high risk approach? And these are the different outcomes associated with that. And as long as everyone in the room is aware of the possible consequences of these decisions, I think that's a good way to manage those discussions.
Yeah, lovely. Now, today we're doing what we refer to as, I guess, clinical cases podcast, where we probably more try to delve into a particular case or an example that you might have dealt with. And we're going to do that today with throwing you a case that you've worked with recently in sport around an intramuscular tendon injury, given your knowledge in that space from your systematic review and your work that you're doing. So to kick us off, did you want to fill us in, give us a little bit of an overview of this case, and then we'll move through some steps?
Yeah, so he was a 26-year-old hurler. So he had a history of recurrent right hamstring injuries. His initial hamstring was 4 years ago, and since then he typically had 2 hamstring injuries per year since, missing anywhere from 4 to 8 weeks per injury. His most recent injury at the time of presenting to me was a 3C of the proximal biceps femoris, and the mechanism of injury was sprinting. This guy had plenty of recurrences, as we've already mentioned, despite undergoing good progressive rehab with several different therapists, and always displaying good pre-season NORD board baseline. So he was always able to produce about 4.9 times his body weight bilaterally on a NORD board at pre-season testing.
Okay, so interestingly, and when you were presented with this injury on your first look of things, what was your thoughts around both the diagnosis and the prognosis? And given that you've obviously had an imaging there, how did that influence your thought process around time and return to play, working off even what we just chatted around before?
So looking at the imaging results, first of all, it was graded as a 3C biceps femoris. There was also a suggestion of some loss of tension, which would suggest to me that there is a significant involvement of the intramuscular tendon here. So this is going to be on the more extreme involvement of intramuscular tendon compared to the case we were talking about in regards to the systematic review earlier, which may be mainly a B injury with some tendon involvement. The majority of the injury here was within the tendon. Interestingly, clinically, on assessment, so once the acute stage settled down and we could actually see what he's like functionally, he had increased range of motion on the maximum hip flexion passing knee extension test. And I think this is a pattern I would see quite regularly with those higher grade intramuscular tendon injuries, where they actually have an increased true tissue extensibility on this test compared to the uninjured side, which may correlate with the loss of tension on the MRI. Also, he had reduced muscle bulk in the lateral hamstring, and he actually had a significantly hypertrophied semimembranosus, semitendinosus, and adductor magnus on the medial side. So this then suggested to me that there was some sort of pattern of compensation with his rehabilitation to date, or with his general adaptations to loading. Always the first time I meet an athlete, I kind of want to understand what his goal is, what does he want to get out of this process, what's important to him. And to him at this stage, he was just completely fed up of these recurrences. He didn't care how long it took. He just wanted to try and stop these recurrences and take as much time as required to do that. So in terms of prognosis then, factoring in both the injury, so if we take a 3C biceps femoris with some loss of tension in the intramuscular tendon, we're looking at somewhere around 8 weeks straight away. That's what's going to take. But if we look at the specific adaptations we think we're going to have to get after with our rehab based on our physical assessment, we know that we're going to have to get some hypertrophy. into the biceps femoris, and we know from a tissue adaptation perspective that's going to take at least 8 weeks. We also know that we have to try and increase the stiffness of that intramuscular tendon, and we've lots of really good research in the last 12 to 24 months coming out on how long it takes to actually bring about tendon stiffness. So we know from a paper by Mao et al. In 2024 that 12 weeks of progressive, properly loaded eccentric exercise, 12 weeks here brought about favorable adaptations in the physiological cross-sectional area of the intramuscular tendon or aponeurosis, which then is related to tendon stiffness. We also know by a paper from Stephanie Lesenchuk in 2024 again that 10 weeks was not enough to bring about this adaptation. So straight away thinking about that hypertrophy is going to take 8 weeks plus to get after the tendon stiffness, which I felt was an important contributing factor for this athlete. That was going to take 12 weeks. Even though this was a 3C injury, and if you look up the average return to play times here, it's going to be somewhere around 7 to 8 weeks. We actually put a 12-week return to play on this case simply because we wanted to factor in what was the athlete's goal here. And the ultimate goal here was to try and stop the recurrences, not just get back on the pitch as quick as he could.
Beautiful. I think that's sort of, you put the decision-making process there and highlighted the reasons why and how that fits together. So that makes total sense. We will delve, for those listening, into, I guess, how you might look to try and restore both hypertrophy and the stiffness component through our rehab. But another one I get asked with these injuries, and you mentioned the loss of tension. Many years ago, there was probably more surgical intervention happening. Is that even a consideration or conversation now? And whether or not it was for this athlete, and that aside, I guess, where does surgery fit in proximal tendon injuries of biceps these days for you?
I think it's definitely something that with the high grade injury like this, some loss of tension, big history of recurrences, it's always going to be somewhere in the conversation. And just so we can give the athlete the best possible information to make decisions, I'd always ask for an opinion with these cases, whether that opinion is from some of the excellent sports physicians or orthopedic surgeons that I work with. I'd always reach out to them and either get them to log in remotely and look at the imaging or see the athlete themselves in person, just so we can give the both sides of the coin, I suppose, to the athlete to help them make their decision.
Yeah, excellent. And you talked there to, I guess, some of the findings or findings that you noticed within the athlete that you needed to address, being around the hamstring, hypertrophy and tendon. Outside of the hamstring, was there anything that you and your team thought was some of the key contributing factors you were going to address in the hamstring at all?
Yeah, from a kinetic chain perspective, there were two things. There was basically some radicular pain that the athlete had on occasion, and there was a history of an old knee injury. So just to talk a little bit about the radicular pain, first of all, this athlete is a hurler, as I mentioned. He's an elite hurler, so that means he's putting in about 20 hours per week into a sport. But these guys aren't paid, they aren't professional athletes, so what's happening is they're working 30 or 40 hours a week on top of it. And then after work, they're driving an hour and a half to training, an hour and a half back home, and then back up early again in the morning. So there's lots of stressors there. This guy in particular was an engineer, so he was spending a lot of his time sitting at a desk working at a computer during the day. So what we found is that he wasn't doing much movement from 9 a.m. till 4 p.m. And then by the time he got into training, he would always have a positive slump test on that side. So what happened then was that would be something that we had to make sure was clear before he got back onto the pitch, particularly in later stage return to play work when he's really starting to open up the legs and get up that max velocity again. We know that increased neural tension or that neural mechanosensitivity is going to affect coordination of the muscular contraction through the tract of the sciatic nerve. So I felt that's an important one to look out for, and it's something I would see quite regularly with recurrent hamstrings. In terms of the knee injury, the athlete on that same side had a lateral meniscectomy 5 years previously after a varus type injury. On clinical assessment, there was no real signs of any effusion or anything like that. But interestingly, on his dial test in 30 degrees knee flexion, so prone, just measuring tibial external rotation, he had increased laxity on the recurrently injured side as opposed to the other side. So that would suggest to me that there was some sort of components of posterior lateral corner to that injury he had a couple of years ago. And if we think about the structure of the posterior lateral corner, the distal biceps fem tendon is going to be a big part of that, that helps stabilize the posterior lateral corner of the knee. So if there is a lack of stability at that area of the knee, the biceps femoris has to work harder to try and stabilize that, while obviously contributing to what it does in terms of high velocity running. We already know from our clinical exam that the biceps femoris injury maybe had a loss of tension, maybe had a loss of muscle bulk, which is suggesting a altered activation pattern. Also had the radicular pain component, and now was being asked to work harder to help stabilize the knee for the posterior lateral corner deficit. So all these things led that biceps femoris to be in a position where it was being asked to do extra work, and it wasn't strong enough or prepared enough to do the work it was being asked for.
Yeah, right. Very interesting. Okay, so I'll pass on. I guess addressing. See, I think the second piece there we'll talk to around probably how we address some of the biceps fem, and I'll leave the physios out there to work through how we obviously navigate through some positive slump work. With, I'm assuming, some good old-fashioned 101 physiotherapy work and different mobility aspects. But what techniques, moving into, I guess, now getting, you've looked at these aspects, you've got a good idea that we're talking 12 weeks here and can map out a bit of a plan in those early phases where we are trying to optimize tissue healing. And, a reference maybe our podcast last time, an episode or two ago with David Power from Aspetar, talking around some different loading strategies early on to try to improve a bit of collagen synthesis. What do you advise, or what did you do, whether that's offloading and obviously and loading in that early phase, and how did you go about that?
Yeah, so I suppose the first step is to protect it. So to avoid putting extra strain through that area, we know that from the British Athletics rehab group that there was improved outcomes managing these injuries when they protected the injured tendinous tissue from lengthening or strain type loading until after 2 weeks. So we knew straight away we weren't going to do any sort of lengthening or heavy eccentric work until then. But it was important to just educate the athlete that that's what we were trying to avoid in the early stages, because sometimes there's a tendency, if the athlete thinks that, okay, if I start stretching this could make me feel a bit better. So that education piece is really important, I think, at the start. In terms of what we specifically do with the athlete then, is we would have used ice compression using a game ready machine, and I think that could be quite good for addressing any neuromuscular inhibition. When it came to early loading, so this would have started maybe 2 days after the injury, we would have used some synergistic work, just using some lateral force transmission. So like doing some side-lying ad or abductor lifts. So the hamstring is working as a synergist, but there's not any stress or strain really, or not any significant stress or strain going through the tissue. So the hamstring is working more as a stabilizer here. And then from about 5 days post, we started to work with some inner range isometrics. And again, just doing a really, really slow build up, like David would have spoke about in your recent podcast, just making sure that we're not generating the force very quickly and making sure that we're not letting go of the force very quickly. That can certainly help with some collagen synthesis with the tendon. And then after 5 days, so at 5 days, we were working in inner range. As over the following 7 to 9 days, so to bring us up to the 14, we progressed from inner range to mid range to outer range isometrically. And then normally what I will do is I will track isotonic loading one level behind it. So if we're working towards, maybe say if we're at the stage where we're 11 days post injury, 12 days post injury, and we're maybe 3/4 to outer range, that would mean then at that stage, then I'm loading the athlete isotonically from inner to mid-range. So I'm just a little bit back isotonically compared to isometrically.
Can you give us a bit of an idea on the time of loading that you would utilize for how long you might do those isometrics and sets that come with that? as well as, I guess, how often, what's the frequency of your loading here when you're looking at early phase isometrics for the collagen synthesis and healing aspect? Are we doing that daily, twice daily, every second day? How do you sort of bring that all together?
Yeah, we would look for kind of somewhere around 2 to 3 times daily, early doors, just not only for the collagen synthesis, but also trying to address the activation piece, especially in this athlete. When we think back on it, we saw that there was a reduction in biceps femoris muscle bulk. So that would suggest that there was an activation problem with the biceps femoris. So we know straight away there's going to be some work we have to do from just an activation perspective, from a neuromuscular coordination piece. So it was important to get it done regularly 2 to 3 times per day. In terms of duration of these isometrics, we wanted to be careful at the start to make sure that we're not getting any sort of creep effect. So we did in the tissue. So creep effect is when there is a change in length of the structure with a sustained loading. So we didn't want to do our isometrics too long. So we weren't going to 30 to 45 seconds. We didn't want it to be too short either, because they were going to be relatively easy and we didn't think there would be any adaptations from it. So we probably ended up somewhere in the middle, around that 10 to 15 to 20 seconds per hold. We might do
Yeah.
three or four reps 2 to 3 times per day.
Yep. Okay. Perfect. And just to give us a bit of a visual, exercise selection wise, obviously where we're talking mid, and you're talking 3/4 range and outer range, my head so just goes to someone sitting on a hamstring curl machine, a prone hamstring curl machine, which I'm sure may have been used. But what exercise selection did you use, and from that end, or other isometric pieces, or how did you do that?
So we want to activate the biceps femoris. So we know from Matthew Bourne's work that there's going to be more activated with the hip dominant strategy. So we tried to use some bridging. So we literally just started off with a bridge with the knees fully bent, 90 degrees plus bent, and slowly worked it out. We also then played around with foot placement or foot position. So we know that the external rotation of the tibia is going to bias, again, the biceps femoris. And at this stage of the rehab, I think it was really important to be questioning the athlete. Where is he feeling this working? Making sure he's not feeling it working on the inside, the medial side, because we know that is probably his go-to pattern from his more hypertrophied semimembranosus and adductor magnus that we discussed earlier. In terms of isotonically, yep, the hamstring curl is a really, really good way to go at it. It might just be a way that the athlete might need a certain position, a certain bit of help just to get out of that stretched position. Another nice way to do it is slide boards. So maybe to just do some early eccentric loading where they slide out single leg about maybe halfway out, or double leg to start before progressing to single leg, and then just let the bum come down to the floor and pull in then bilaterally, concentrically, just to make sure that we're loading that isotonic piece, which again is going to be one level behind the isometric.
Yeah, perfect. Okay. Yeah, it's good to be able to see exercise selection and choice and how that comes together. So, all right, we're moving past a couple of weeks and we're feeling like we've been trying to get some of that targeted loading in. I guess thinking forward, moving into a bit of a next stage, and you mentioned things around hamstring stiffness and hypertrophy work. I guess, how are you bringing that in? Or first and foremost, how are you starting to address those aspects within your rehab, and what are we going after, and how's it look?
So when we think about what we want to get into the structure itself, so if we think about hypertrophy and what's that actually going to help us with, it's going to help us with peak force. So peak force production, we know from the anatomy of the biceps femoris, it's going to be very much associated with peak force production. We know that this is going to come from both activation of higher threshold motor units and the actual size of the muscle itself. So in terms of getting after the size of the muscle itself, hypertrophy, we use concentric based hypertrophy for this, which is suggested to bring about more sarcomeres in parallel, which will increase the physiological cross-sectional area of the tissue. We decided to load the athlete here in a position that's optimal for force production for the hamstring. and that was a standing leg curl. So imagine, say, you're using a knee extension machine and the back of the athlete's calves are against where normally the front of your shins would go if you're using the machine. So you position the athlete in about 45 degrees hip flexion, leaning forward, maybe holding on to the seat. You externally rotate the foot that you're going to curl with, and you slowly curl that up, bringing the heel up towards the bum in that standing leg position. And we work the athlete here between about 100 degrees of knee flexion and about 30 degrees of knee flexion, because we know that the force will drop off once they go beyond 30 degrees, once they get closer to knee extension. So we want to keep the athlete in that position where they're working really hard. Again, when it comes to hypertrophy, we know that as long as we take the athlete close to failure, so it is across a variety of rep ranges, that will elicit some hypertrophy. So what we like to do was maybe if we were doing this exercise twice per week, if we were doing 4 to 5 sets, we might do 2 or 3 sets heavy in that 6 to 8 rep range. And then what we might do is we might do 2 sets a little bit lighter, so maybe around that 10 to 12 or 10 to 15 rep range. Towards later on in rehab, as this progressed, and we were really at the stage where we're maximizing hypertrophy, we probably use some old school bodybuilding techniques such as drop sets, rest pause sets, myo sets, just to try and get that intensity into the tissue. I think that's really important as well, to communicate with the athlete in terms of even to show them with the unaffected side, what does a 1 or a 0 reps in reserve feel like, and then allow them to apply that, okay, this is close to what I should be feeling on the other side. In terms of stiffness, again, we know that from Stephanie Lazenchuk's systematic review, I think it was 2022, we know that to improve tendon or aponeurotic stiffness, we need to put strain through the tissue. So for strain through the tissue, we want true range, heavy eccentrics. Again, to drive tissue adaptation, the intensity of this has to be enough. So if we're doing a eccentric hamstring curl with a weight that the athlete can curl up themselves concentrically, in my opinion, that's not going to be enough to drive tissue adaptation, because we know that we should be 30 to 40% stronger eccentrically than concentrically. So that's why I've used an awful lot in the last year or two is the 2 legs down, 1 leg up, seated hamstring curl in 120 degrees of hip flexion from that Mao paper in 2024 that we spoke about earlier. So we would work up to doing that exercise. So we would get to the stage where we're up again, 2 legs down, 1 leg up, maybe looking at 4 sets of about 6 reps with the external foot, with the foot rotated externally, just to try and bias that biceps femoris a bit more. I think that's a really, really important exercise to try and get into hamstring rehabilitation if we're chasing stiffness in the tendon. As an alternative, sometimes athletes will say to me, I don't have access to a seated hamstring curl. What else would you do? You'd probably look at an RDL pattern if we're trying to hit the biceps femoris. But again, we have to think about how can we actually overload this tissue eccentrically. So if we do a split stance RDL, which would be a very, very common one to use, and that we just slowly lower down and pull back up, and again, that we're not really struggling that much concentrically with it, I would just question, are we challenging the structure enough to drive through tissue adaptation? So sometimes what I like to do is I get to the stage where they do a conventional deadlift, they stagger their stance, and then they slowly descend into that split stance RDL and try and again maximize strain at the bottom on the tissue, maybe hold for 3 seconds and then just let go of the bar. Obviously, this is not going to be suitable for every athlete, especially if they've any sort of history of extensor lower back pain. But again, maybe it's another alternative to consider chasing that tendon stiffness for a biceps femoris injury.
Okay, so breaking down, I guess, both of those a little bit. One, I do know actually we have a photo of the standing hamstring curl exercise you're talking around in one of our blog articles around this takeaways from our hamstring event in Italy. So there's part 1 and part 2, so listeners can go and see that that image there that you're talking to. And I guess also in that image, it was referenced probably a degree of when you're in the standing position to either have the hip flexed or standing sort of more upright. Was there one that you would advocate in this athlete, or did you sort of mix that hip position up a little bit to more bias, long head and short head a bit?
Yeah, we probably mixed it. I would say if we're thinking about it, it was a proximal. So we were doing maybe 2 sessions with hip and 45 for every 1 session, a bit more upright.
Yep. Beautiful. And coming back to our seated hamstring curl, the lengthened state eccentric, I guess that's a relatively high level exercise. And I sort of, in our questioning, we went from sort of, some of that tissue healing loading and then sort of to jump to that a little bit. What did we sort of miss there? Like, what do you need to do to bridge the gap? And roughly, as a guideline for this athlete, when did you start to bring that exercise in?
Yeah, so we know after about 14 days, we're going to start progressing this tissue towards more lengthened type loading. As you mentioned already, that 2 legs down, 1 leg up is probably the very end stage of that loading. So what's a nice piece to start working towards that is maybe doing an outer range iso. So how we would do that is maybe in about 90 degrees hip flexion on a seated hamstring curl again. We would get both legs to curl down only about 20 to 30 degrees. We would lift the unaffected side with the affected side foot and external rotation again to bias to biceps fem. And we might do some heavy isos in this position, 6 by 6 seconds type loading here, because it's going to take the athlete 3 or 4 seconds to be able to generate the maximum amount of force in this position. That could be a nice way to bridge the gap. And then as a progression, then we could do that outer range iso in a position of about 120 degrees hip flexion. So just like the position as described in that Mao paper. Then clinically, when we start up into the 2 legs down, 1 leg up, we might even work with double leg down, double leg up first of all, or we could go to double leg down, single leg up eccentrically in just a normal hip position, so just sitting upright on the hamstring curl machine, and then we can progress again to putting more strain to the tissue by dropping the chest forward, getting into that 120 degrees hip flexion as described in that paper.
Yeah, beautiful. We sort of like covered off a little bit there on your mid-stage rehab. Is there anything within that there that was sort of missing? And I guess also one thing I'll sort of raise and touch on, obviously we're talking around the level of stiffness and use that term sort of interchangeably, but is there room for, do you progress from those length and state eccentric training to more any of the rate of force development piece where they might be doing switching and really trying to create that stiffness within the tendon in those more dynamic movements? Is that something you need to do, and is it something that you did?
Very, very good question. So we know if we look at the literature again, we know from Stephanie Lazenchuk's systematic review in 2022 that plyometric type loading is not as good as creating stiffness in the tissue as strain type work or via heavy eccentrics. However, there probably is some sort of neuromuscular stiffness here from a coordination piece to consider here as well. And so I think rate of force development exercise can be really, really good for here, such as the switches like you described, or off a GHD, med ball catches or reactive catches. Also, what this type of exercise does is it changes the rate that the strain is applied to the tissue. So the strain is applied to the tissue much faster than it would be with obviously the slower type heavy eccentrics. And if we look at Dorn et al.'s paper that everyone references when it comes to running demands, we know that between 7 and 9 meters per second that the rate of strain applied to the tissue increases significantly. So even though that these gym-based exercises don't get us anywhere near that rate of strain, that level of change of rate of strain as we will on the pitch, it can be a nice middle step, I suppose, to tick off that saying we have done some of this before we really start applying that strain very, very quickly in a sprinting context.
Yeah. So if I throw a context for you here, you've got a 12-week rehabilitation with this athlete that you're working through. If you had a 4 to 6 week hamstring rehab, and is it something that you would include as much when you've got the opportunity to sort of get them going on the pitch, and how would you balance that?
It's probably something I would do, but it's not something that I would spend a lot of time pushing with the athlete. I would look at it as two ways: that are we getting the adaptations in the gym and in the structure that what we want to try and maximize or speed up that healing, and then number two, are we getting the going on the pitch? But I do think sometimes those rate of force development exercises can be a really nice primer that they can do before their running day. So for instance, say if we have that 4 to 6 week injury, that what they might do is they might come in, be physically assessed, then do their team activation, then do some maybe 2 sets of 4 reps for 2 exercises of rate of force development exercises. Then they might do the running progressions on the pitch, and then they might go into the gym afterwards for their heavy eccentric loading, and then we would give that tendinous tissue 48 hours off to adapt after that. It doesn't mean that the athlete can't do anything. They could come in the next day, do lots of off the feet work, general lower limb power stuff, but we just need to give that tendon the 48 hours to adapt.
Yeah, okay, perfect. And with, I guess you mentioned field based there, and where we're sort of edging towards. How did you balance the speed introduction for this athlete? You're obviously doing a fair bit of volume of work there around the hamstrings and some high level eccentric work. I guess, what was your guideline to just get running faster? So let's call it 80%. And what was your guideline for running above that? So 90% plus. And yeah, how did you balance that with some of these things you're still trying to maybe build? Because I imagine you mentioned 8 weeks to get some hypertrophy. That's 8 weeks as a minimum, and then stiffness even more. But you're still going to play it 12 weeks. So you're still trying to balance all these things together. How did you do that?
I think it's important to just sit down and plan out your overall week here. If we're looking for pushing hypertrophy, we know that we probably want minimum 8 to 10 sets of that type of loading per week. So if we aim for even 12, we could spread it out as 4 sets over 3 days. Now that's going to be a lot of loading, considering they're probably going to be doing their strain work afterwards. So at this stage, this athlete would generally be on the pitch 3 days a week. So at that stage, maybe they're only on the pitch twice per week. And maybe if we think about the up to 8 weeks, we're chasing hypertrophy. It doesn't make much sense to be still chasing hypertrophy as the athlete's starting to really, really sprint and move faster with the pitch progressions over the last 4 weeks. So in those 8 weeks initially, we're probably looking at exposing the athlete to progressive high-speed running, but maybe keeping them away from any sort of real danger zone. So we might cap them at about that 80% running. The key thing is, as we introduce a new speed to the athletes, so say they're running at 60% last week, you have a few days off, come in nice and fresh, good to go, we're going to push to 70%. It's important to expose the athlete to that speed safely. So how we can do that is just give them a nice fly through with a nice build up acceleration zone, maybe a 20-meter acceleration zone where they have 20 meters to speed up, then maybe a 30-meter holding pattern, and then a 20-meter decel pattern, so that they're not trying to get up to that speed very, very quickly. Then when it comes to looking at change direction work, so we'd often start change direction work once the athlete is at about 70% of what their previous max speed was on a GPS. But we're not going to start change the direction work at the 70% intensity compared to where they are for the max velocity work. So we might come about 20% back. So we might kind of start change the direction pace at 50%, 60%, and slowly work our way up for that. But always considering that max velocity is probably going to be that 20% or so, give or take, subjectively anyway, in terms of intensity. That max velocity is going to be 20% ahead of change of direction or accels and decels.
Yeah. Okay. So good answer. And your level of so let's say we've built up where we're maybe transitioning into doing sort of 80% speed, where you might need to modify and adjust some of the loading throughout the week a little bit to potentially scale back. What are my markers for really sprinting, for moving past that? So, and define sprinting on what you would think that's our main marker. What defines us to get there, and then how do you start that?
I think it's going to be about what can the tissue tolerate, how comfortable are we with exposing the tissue to those high rates of force, high rates of strain. I think that's going to be about how the tendon is working or how the tendon is functioning. I think that we can lean on eccentric testing to do that. I think we have to be very, very careful with how we select our tests. Again, I think a Nordic can be very, very useful in some return to play decisions. But if we go back on this athlete that we've been discussing, this guy was always producing 5 times his body weight every single preseason and was breaking down. And if we consider the context of that, then again, he has a hypertrophied medial hamstring and an atrophied lateral hamstring. We know that the Nordic is going to be an exercise because it's knee dominant that's going to favor more the semi-10 than the biceps fem anyway. So what I really like to use here for making this decision, can the athlete sprint or not, is leaning on an eccentric IKD. So in a seated IKD, testing the athlete eccentrically and comparing that to relative to body weight. So I think an ideal score for eccentrically would probably be somewhere around 2.4, 2.5 times body weight. And concentrically, we would probably settle for kind of 1.8, 1.9. But I think eccentrically, we would want to have the athlete produce at least 2 times body weight to be comfortable in terms of can we slowly expose this athlete to really, really getting after critical speed.
Yeah, right. Okay, there's some pretty good numbers. And obviously, as good target numbers, we sometimes don't always get our athletes to exactly those targets because for whatever reason, but we can still make decisions around, progressing and with the knowledge that we have in front of us. How did you go with this athlete? What was he sort of pushing and how did that guide any process of decisions thereafter?
So I think at the point of sprinting, the one thing we'd agree with this athlete is that return to sprint, he just had to have that eccentric function. I think that there was maybe aiming for maybe 2.4 times body weight for him to be back returned to play eccentrically, which he didn't achieve at the 12-week timeline, and he still went back and played. But what was more of a non-negotiable was him achieving the 2 times body weight before he went back sprinting. So I think that's really, really critical in terms of our confidence to be able to push him on. But I think we also have to consider the athlete in the center of all this. So it would have been an interesting conversation had he not hit his numbers in terms of returning to sprint. And what would that have meant? It probably would have meant an extension of the return to play by certainly another 3 to 4 weeks. And how he would have responded to that, I'm probably not sure, Nick, to be honest with you.
Yeah. So you probably put more weight there on the 2 times body weight, which was the concentric aspect of that. So let's say that was where you sort of had to have that, but if they're operating around 2.2 to 2.3 or around on the eccentric, you could probably be a pass mark. Why was that?
So probably I didn't explain myself that well there, Nick. What I meant was that he had to have two times body weight eccentrically to sprint.
Okay. Right. Okay.
And then at return to play, we were targeting 2.3, 2.4. He didn't get that, but our advice to the athlete is that if he needs to be able to produce 2 times body weight eccentrically before he goes sprinting.
Okay, perfect. Yeah, we've clarified that nicely then. All right, good. So you've used obviously IKD within this rehab process to obviously give you more of the information. You touched on Nordic there because and whether or not that was causing some of that maybe change in the balance across the hamstrings and the more medial aspect, but it might not have been addressing it regardless. The depth deficiency there, given that he was obviously punching 5 times body weight, and you've been doing that and still having issues. In your programming, would you still include the Nordic in his program throughout the process with that information in mind?
Not in this athlete, no, I wouldn't have. For other athletes, yes, absolutely, I would program Nordic, especially if we want to get after our semi-10 or even biceps short head in some T junctions. I'd use some Nordics at the appropriate time. But for this athlete, no, I felt that we had to line our ducks up in a row to make sure we were really, really clear with what we were going after. And of course, the Nordic is going to put some strain through the biceps, and we're going to get some level of tissue adaptation in the biceps. But when we were aiming to really maximize that adaptation in terms of both hypertrophy and tendon stiffness in our biceps long head, I just felt there were better options for this particular athlete.
Yep. So you've really just, I guess, you've run us through what you were really trying to target, and you stuck with those exercises to get those adaptations, and not necessarily just put in exercises because we know there's sort of some good evidence around Nordics. You've obviously applied it to your athlete. I'm going to throw a bit of a curveball one at you, and just back on the IKD. Is there anything around a ratio of their strength? So you mentioned obviously the concentric strength and the eccentric strength. Is there anything around where one athlete might be really strong eccentrically but not strong concentrically, or vice versa, that then gives you some information that you go after, or is that just sort of taking it, trying to utilize numbers and that sort of stuff too far?
I think it can definitely guide what way we need to train this athlete, and I think it can certainly guide what way their maybe strength and conditioning needs to go once they're back on the pitch. I think that if we think about concentric force coming mainly from contractile fibers, and if we think about there being a massive contribution from non-contractile tissue for eccentrically. So even if we think about their return to playing markers, so say the athlete hits the ideal 2.4, 2.5 times eccentric IKD, but then they're only producing 1.5, 1.6 concentrically. So from a clinical reason perspective, that tells us we need to get after our force output. And how we do that is then we make sure that we're activating those higher threshold motor units, and we're also getting after, as appropriate, is some hypertrophy in that tissue. But also, if we think about those contractile elements are going to fatigue. So if you have an athlete that's maybe producing 1.6 times body weight on an IKD, but then is miles ahead eccentrically, that athlete is probably going to be under a little bit more pressure as they fatigue, because because they don't have as much sarcomeres in parallel, they're going to fatigue earlier. And when they fatigue earlier, they start relying on those non-contractile elements more again, causing some creep in that tendinous tissue. And maybe that could be part of the reason why some of these intramuscular tendons re-injure.
Yeah. Okay, that's it. Yeah, interesting point. And we won't, I was about to sort of have one more question and wrap things up, but just this one I'll sort of throw, the fatigability piece. How do we sort of, without IKD and the like, how do we probably determine that there might be a fatigability aspect within the presentation that's in front of us that might lead to something like that? And how do we go about addressing that in our rehab? Is it purely just around time and tension work, or do you do more endurance-based hamstring, or is it there's other elements to try and get that metabolic work?
Yeah, if we think fatigability is a factor, it's something that I would program obviously at the end of the rehab program, and I would program a relatively simple exercise like a single leg elevated box bridge, and we might do 4 sets of 20 to 25 reps with minimal rest in between. Or we say to the athlete, right, okay, you're going to hit 100 reps here today, keep going and try and do the 100 reps as fast as you can, and actually record their time and progress that over time, monitor it. That could be a nice way to make it a little bit competitive for the athlete as well. In terms of knowing whether, without say, if we didn't have IKD, how will we know that fatigue is a factor? I think if you do a deep dive into the athlete's injury history, are there injuries happening later on in the game? Talk to their S&C. What is their level of overall physical conditioning? What's their mass scores compared to other people on the team? What position are they playing? I think it certainly is. There's lots and lots of factors to consider there as well. And really, if we think about prevention of re-injury, prevention of sports injuries in general, that's going to be a complex system. It's not as simple as saying that if we have a reduced eccentric strength, then that athlete is going to get injured. It's what does it mean when they have reduced eccentric strength, when they're in a fatigue state, when there's some even psychosocial stressors going on in their lives. It's what does that pattern of events contribute to. So I think it's important for us to look for patterns in that. That's a very, very hard thing at the stage now for us to be able to identify especially in our clinical practice, just working with teams. But if we can try and identify those patterns that the athlete did get injured when he was more fatigued or when he was less fit, then that gives us, I suppose, a bit more weight or a bit more clinical reasoning to go off that this is something that we need to program.
Yep. All right, lovely. And I guess, just that final piece around, okay, we're about to return to play and you've moved through the clearance to sprint and you've been sprinting, and you say you played around 12 weeks, as you mentioned. How many weeks do we want to see them with that high-level sprint exposure and training integration for you're confident on a return to play? Do you need to see them just run that 90-95% once and you're seeing that as a clearing test, or do you need to see that being repeated over a period of time, and if so, how long?
Again, depends on the athlete in front of you, but with this guy who's high in recurrences, we would want probably an exposure of above 92 to 94% for maybe 2 weeks in a row. We would also look at him completing at least a full week of training before being back in with the group. So like if he's returned to play at 12 weeks, that means he's returned to full training at 11. That means then at week 10, then towards the end of week 10, he's probably in modified training. So it's just to make sure that we're not going from he's running on the side of a pitch with us, being thrown in straight into that chaotic environment, because even from a cognitive load perspective, we can do things with our rehabilitation to try and target that. But at the end of the day, the sport is a sport and the athlete has to be ready for that as well.
Yep. Mate, very comprehensive. One final piece is around the, I guess, ongoing prevention, and it probably fits with what you're doing, which is obviously in your prof doc around surveillance piece around the subsequent injuries. What did you do for this athlete? So he's back playing. He's had obviously a history. You've built up. You've done your sprinting. You focused on those key areas we've talked around. How do you maintain that then? And what level of exposure is enough? And what are the couple of key things that you picked out that just had to be in there and had to be in there consistently? And how did you get that in the program?
So starting from the end, I think the most important thing was exposure to maximal speed. 1 to 2 times per week. Making sure that box was ticked, making sure coaches, SNCs, player, they all understood that. The next thing from a pitch perspective, or from a gym perspective, was making sure that there was an adequate stimulus of eccentric load to try and maintain or even further improve the efficiency of that tendon. So that was done in a communication piece with the athlete and with the coaches, saying, okay, we need to really, really load this guy heavy, but preferably that has to be the day before a day off. So say if their heavy pitch loading day was a Tuesday, then straight away they would train, say, between 7 and 9 p.m. on a Tuesday. Could be freezing cold in the winter. The rest of the lads are going up, getting a shower, getting some food, whereas he was straight into the gym doing 4 sets of heavy, 2 legs down, 1 leg up, seated hamstring. And even though he was fatigued after training, I still think that was probably the best time of the week to do it, because then he had over 48 hours off his feet before he's going to be back on the pitch running. I think just making sure that the athlete understands the intensity that's needed to drive these tissue adaptations, that one exposure of this eccentric work per week is better than him doing Nordics on the side of a pitch twice a week. It's just a bit more specific for him and a bit more challenging to actually drive the tissue adaptations.
Yeah, great, mate. Very good, very comprehensive. I've picked up a lot, and it's. I hope, given the questions I've sort of been getting just from some physios around in Melbourne, Australia. So I think I've tried to relay that within that, and hopefully that comes out to listeners. But very great insights and really well thought out process. So thanks, mate, for joining. And look, if people are keen to sort of touch base and reach out to you, you're happy for them to do that? And if so, how do they go about doing so?
Yeah, absolutely. I don't have too much of a social media presence at all, but probably LinkedIn would probably be the best place to find me if they want.
Perfect. Well, thanks again for joining us, Michael. Appreciate your time, and we'll chat to you soon.
Cheers, Nick. Thanks very much for having me.